Hello everyone, and thank you again for joining us for the fifth in our workshop series, the Improving Healthcare with Simulation workshops. Putting on these workshops to connect with everyone interested in simulation, process simulation and improving healthcare. And this month, delighted that we are looking at balancing patient satisfaction and staff efficiency. And in particular, we're looking at a project from Geisinger Health System, and that's the logistics of the meal delivery there. As I say, delighted we've got two great speakers on the call today. If you just go to the next slide, there we go. And first off, our main presenter is Seth Hostetler. He's a process engineer for care support services at Geisinger Health in Danville, PA. Seth is also a current PhD candidate at Penn State University, studying industrial engineering and operations research, and that's with a research focus in healthcare systems engineering. And for Geisinger, in his position, Seth is tasked with driving innovations within the care support processes. This includes leading and performing strategic process improvement projects across the health system, and is currently active in research aimed at re-engineering healthcare at Geisinger. So delighted to have Seth speaking with us today about his projects. And Seth is also joined by our very own Brittany Hagdorn, who's the North American lead for healthcare for Simulate. An ASQ Six Sigma black belt, Brittany has experience with Lean and Six Sigma project management, as well as production planning, inventory management, business development and strategic planning. So a great calibre of speaker, and really looking forward to the workshop today. But just a few quick housekeeping items before we start. Please click on to the next slide, Seth, thanks. Just before we get started, everyone's muted just now, and that's just to let us have a smooth run at the workshop. But if you do have questions throughout, then please use the question panel or the chat panel on your right hand side. You'll see in the doc on your right hand side. Just type them right in there and we'll get them across to the guys to see what they how they can get involved in the discussion, how they can help. And there will be time for Q&A at the end, but as I say, if you have questions throughout, then please do ask them. Recording and slides will be available on simulatehealthcare.com also, and we'll also email a link out to everyone that has attended today. So it gives me great pleasure then to introduce Seth, as I say, and Seth is going to be talking about balanced patient satisfaction and staff efficiency at Geisinger. And Seth, it's over to you.
Thanks, Stephen. So I guess I first wanted to start by elaborating just a little bit on the care support services aspect of my job. So I think what'll be very interesting about today's webinar is that it's not the traditional patient flow, ED layouts, looking at the OR. It's the other aspect of healthcare. It's the operations. It's all of the things that actually support that care delivery process, and that's really what care support services at Geisinger is. It's a new division. It encompasses our enterprise pharmacy and enterprise supply chain, looking at everything at how meds are delivered to equipment distribution to food services. And so that's what I want to talk today about, is how we provided some insight to management as they transitioned from a meal delivery system where it's a traditional method that everybody will eat breakfast at 7 a.m., lunch at noon, and dinner at 5, and they just take up meals and patients get it whether they want it or not. And transitioning to an on-demand meal delivery system where patients are provided a menu and they can order what they want and when they want during our hours of operations, which adds a layer of complexity to the operations. So the agenda for the next hour or so here, leaving time for some Q&A, just talk a little bit more about the intro, the objectives, talk about how the approach we took to this model, and then go through and explain our phase 1 and phase 2. We broke this project out into 2 phases. Really being because phase 1 we needed to prove to management that we could actually model their system. As many of you may have a similar experiences, is that a lot of people in healthcare still are apprehensive of what discrete event simulation can do for them and how it can be used, really just because they're unfamiliar with the tool. And so our phase one was more of a simple model, and we showed that we can give them results and guidance, and so they asked us to continue into a more in-depth second phase. So a little bit more of an introduction here. Geisinger Health System has about 7 hospitals now. We were looking at the main medical center, their food service department, transitioning to this on-demand room service system. It included 18 inpatient units. At the time we had 19. We did exclude the inpatient psych unit because we weren't going to be, their meal system was going to stay as is. So we had 18 units, approximate census of 360 patients across those. And so we were really looking at how, what are the changes going to be in resource management and employee roles, and really in patient satisfaction and service. How is this going to be better for the patients? And that was really one of the driving force behind food service management going down this path, was to improve our HCAP scores, all right, from the surveys post the inpatient stay. One of the things that we were lacking on was food quality and satisfaction with the meal service. And so by providing them with a menu to choose from and allowing them to choose when they ate, we thought, and we are seeing, improvements in that. So some objectives here, 3 simple objectives: create a representation of the new model, use this model to determine how the different parameters are going to affect the service levels as well as resource requirements. So that's where we're getting into patient satisfaction versus staff efficiency, and create some initial recommendations for the system changes. So what we did is we built this new model on top of an existing model we had. So in care support services, we've been working very hard for the last couple years in improving all of our support services, from how supplies are distributed to how patient transport operates, to linen deliveries. And so we have modeled our entire medical center, hallways, elevators, all of the different pathways. We actually, it's very detailed. We had a couple interns spend several months collecting data, getting accurate times, understanding how all of these movements work, looking at congestion factors through our hallway. So we had this detailed network, if you will. And so what we did is essentially add on top of that this new meal delivery system. So we were able to model the food services department, connect it into our hallway network, and then model the activities once they get on the unit, the delivery of the meal to the patient and all of that. So this is a separate model, but a component of an overall model we had previously created.
So Seth, can I ask you a quick question about that?
Absolutely.
So can you tell us a little bit more? Did you originally design that hallway infrastructure, that network, with the intention of repurposing it, or did you find that once you had it, you had a lot more questions that you wanted to answer?
It's a good question. So our initial reason for developing this hallway network, our hospital model, is that what we were finding is there's a lot of wasted trips in our department. So there's a lot of deadheading where we go out with supplies on a cart, drop off those supplies, and we come back empty. Or in our old food services system, we'd go out with the fresh meals, drop them off, and come back. Later on, we'd go out with an empty cart, pick up the dirty trays, and come back. And what we really, the reason we went down this path to look at the entire hospital is trying to understand the overlaps of these departments and how we could start integrating some of these trips and removing the waste throughout the entire system, trying to take more of a global view of the support services rather than looking at each department individually. And so food services, because we knew they were changing, was one of the last departments that we added into this model.
That makes a lot of sense. So it sounds like it was really a strategic decision that we need to rethink this entire infrastructure, and then you were able to expand that once you had demonstrated that it was successful with some other projects?
Yeah, exactly. Our first department we modeled in there, as far as test to change, we had put in all of the current state modeling and proved out that we could effectively model, again, to gain support from the stakeholders. But linen services was our first test of change that we looked at, and how can we integrate their trips. And so using the modeling, we were able to identify in that case about a 40% reduction in workload. So we've strategically been using the same model, because then we're able to see the interplay between the department and the hallway congestion, and how the other departments are also operating, always looking for ways to coordinate across the department. So in the model itself, the way Simulate is structured, it makes it very easy to kind of add in to different pieces of the model. So that's been very nice.
Great, thanks.
So real quickly here, this is our internal logistics simulation model. The top left shows just our typical process. So there's supply departments or the support services, there's some demand, and then they go through this process. Is it a delivery or a pickup? And so that's a very generic representation, but again, this includes about a dozen different departments in here. And the lower right shows just a section of the model. It gets pretty complex in there, given we have 11 different floors that we model. And you can see some of the statistics on the left, right? So we have 2 miles of hallway, 38 elevators, the 11 floors, 200 network nodes. I think there's about 1,500 objects in there in total. And so it says 35 different transport groups, and that's really breaking some of these departments into different types of transport. Is it scheduled? Is it ad hoc? Is it a dirty delivery versus a clean pickup? So there's a lot of different things at play here, and it's been fortunate that we've been able to keep reusing it and building on top of. So getting into the details of the new food services system here, we decided to split our hospital into 3 zones, and I realize you don't know what the acronyms mean under zone A, B, and J. A, B, and J just refer to our elevator letters, and the zones were based on geography, right? Geisinger Medical Center is made up of about 9 different buildings and add-ons, as many hospitals are, right? And so we just looked at the physical structure and tried to do an even balance across the census and number of beds to create our zones. There's going to be a dispatch timer on the carts, and that means from the time the first meal gets added to the cart, how long do we wait before sending it? Obviously, if the cart becomes full, we'll send it, but do we wait 2 minutes or 20 minutes? And that's going to affect how quick the patient gets their meal. So we investigate the dispatch timer, use a simple nearest neighbor delivery route. The cart and the staff are modeled as one entity, so we always need what we call a host, but just a staff member to push the cart through the hospital. And then so we're doing 3 meals a day, so that's approximately 1,060 meals, and initially we're looking between 5:30 a.m. and 9:30 p.m. for serving hours. Delivery process, very simply here, patient calls in an order. We check, is there a cart already waiting for that zone? If so, add the meal to that cart. If not, start a new cart and initiate that clock. Always check, did we reach capacity? If so, send it out. If not, wait till the timer hits or another meal has been added. As far as data that we needed to input, the distribution of meal orders, so through an external consultant, we were able to get estimates from a couple other hospitals who had transitioned to on-demand room service. They gave us that data in 30-minute buckets, and we adjusted it to our patient census. And then we actually had a couple of our engineers and interns go out and do time studies to understand the times that were spent. So what we found, it took about a minute for the host on the floor to take the meal from the cart to the patient, and then additional 50 seconds if that patient is an isolation patient, right? So if it's MRSA or C. diff, or, right, so if the host has to gown up, get the gloves on, get all of that on, it's going to take extra time. And so we're able to match that to our isolation census. Our travel speed, 185 feet per minute, that's our standard we use in the model for anybody pushing a cart through the hospital. So that takes into account the staff fatigue, average walking pace, but also some of the congestion within the hospital and the true ability to move throughout the hallway. Some of the KPIs we looked at here, essentially we can put them into two different buckets. One being patient satisfaction, looking at service time. So how long did it take to get my meal? The wait time on the cart before routing directly affects that service time. And then we also looked at the percent delivered after 30, 45, and 50 minutes. And this is because management was still unsure what time they wanted to commit to, right? Is it the Domino's, you know, if you don't have it in 30 minutes or it's free? They weren't sure what that time was. Obviously, we're not giving the free meal out, but to get great HCAP scores, we wanted to be able to say you'll have this within 30 minutes, within 50 minutes, and be able to hold up to that promise. So we were able to give them some statistics on that. From a staff efficiency standpoint, we're looking at cart utilization, so how full are the carts when we're taking them out. What's the maximum number of carts used across the day, which is important because that means that's how many carts we'll need to purchase. And then the total number of delivery trips made in the day, again, correlating to how many staff we need. The two marked with the red asterisk, after some initial testing, management thought were the two most important that we were looking at. But really in this first phase, we were considering many metrics. So in our phase one, again, we modeled the carts as unlimited resource because we didn't know what that maximum was. We allowed there to be as many as possibly needed so we could get an understanding of what the system needs were. We looked at 3 different dispatch times that management helped us come up with, 8 minutes, 10 minutes, 12 minutes. Again, that's time from the first meal on the cart to when the cart is sent, whether or not it's full. And we were looking at 3 cart capacities, which were dictated by the available carts for purchase, either 12, 14, or 18 trays could fit on the cart. So we were also helping them make recommendations as to what size carts they should be buying so they were ready for go-live date.
Great. So if I can just jump in here, what we'd love to do is have everybody lend us their expertise. You're now in Seth's position for a moment, and without simulation, what is going to be your recommendation? And so, you know, if you can take a look at these options and let us know what you think is going to be the biggest constraint, right? Is it going to be the carts? Is it going to be dispatch times, or is it going to be the cart capacities? Which of these is going to turn out to be the issue that we need to address? So go ahead and take a minute to vote, and we'll see what the results are. You know, it's interesting, Seth coming up with these 8, 10, 12 minutes, or 12, 14, 18 minutes, or Trey, sorry. You know, how were those options selected that you were going to test? Was it based on somebody's experience, or where did that come from?
Yeah, so the cart capacities were the options that they were considering, and that was based on somewhat of a unit size determination that each unit gets about 2 carts currently, and so they looked at how they do things now, and I think they have 15 tray carts as of the old system. So that's how they came up with those options. Mm-hmm. The 8, 10, 12 were more of just gut feelings from management because we had nowhere to start, and to test everything from 0 to wherever would have been a whole lot of testing. So we asked them to provide us at least a starting point to see if we'd get acceptable results.
Sure. Oh, good. So, Stephen, how are our results looking?
Yeah, that's just sharing that poll now, so we'll share it. So quite a bit of a split across, as you can see now, Brittany.
Mm-hmm. Well, it's interesting. It looks like some folks have picked all 3 of them, but it looks like the strongest part there of the group is actually concerned about the cart capacity, and that being the biggest constraint. So, Seth, if you don't mind taking us through the next few slides, we'll find out which of these was really the biggest issue and biggest decision to be made.
Okay. So as far as results go, right, so we were looking at the minutes here and the cart capacity, and I know this is a lot, but the important piece is down the left-hand side. So as the dispatch timer increased, what we were finding is cart utilization and service time also increased. Max number of carts, number of delivery trips, and service levels decreased. Those in green are good. Those in bad, or those in red, are bad. Right? So, and this makes some intuitive sense, right? So the longer we wait to send out that cart, service time is going to go up, and we're going to run the risk of delivering meals later. And it's actually interesting because it's not a linear path. Right, so if we wait an extra 2 minutes, it's not that we're delivering an extra 2 minutes later, because in that 2 minutes we're collecting more meals. So now we have more deliveries we have to make. So waiting an extra 2 minutes might actually, on the dispatch time, might actually add an extra 6 or 7 minutes into the total service time for the patient at the end of that trip. And then also as cart capacity increased, we found cart utilization went down, which is also intuitive here.
So, Seth, it looks like you have some confidence intervals in here. What was the benefit of doing that, and how did you get that information from Simulate?
That's a good question there. So what we did is we actually wrote out all of the results to Excel. Each time a cart left the system or a meal was delivered, we wrote some descriptive statistics out, really as far as what time, how long had that taken, where was the delivery to. So what we wanted is all of the raw data out in spreadsheet format so we could do any analysis we wanted. And so I guess in full disclosure here, I should say that we were working with a master's student at Penn State who was doing this for her thesis at the time, and so we got an extra little bit of rigor as far as what we might do operationally here at Geisinger from the analysis standpoint. And so what she was doing with the confidence intervals is really looking across these different scenarios which were statistically significant, right? Because that'll be important in making the decision. And so the analysis she did allowed us to actually look and see what was there a difference in.
That's great. I think you really touched on something that's important to mention, which is that I think a lot of folks, when they use the tool, Simulate has a lot of great visuals that are already built in, but a lot of us really prefer to get our hands on raw data in the same way that we get it from doing time studies or out of a health record or something. So thanks for sharing.
Yeah, and to that point, I think a lot of that depends on the model you're doing and the complexity of the results. If you're doing a quick model and it's a little more simplistic, Simulate does have some great internal reporting tools and analysis tools. But sometimes when you're not sure of the analysis you're going to want to do, it's great to be able to just write it out to Excel. Some simple visual logic code in there makes it essentially an automated process. So a little bit of interpretation on the results here. What we're seeing here, again, is a trade-off exists between patient service levels and the efficient use of resources. The 8-minute dispatch timer, again, intuitively is providing the best performance in terms of getting the patients their meals quickly, but the longer we wait, we're more effective in the use of our resources, because the sooner we send that cart, we're going to need more carts and more people to move those carts. So there's a little bit of a trade-off there, right, that we have to consider. As far as the cart capacity, we found that the cart capacity of 12 meals provided the highest utilization, and cart utilization was actually the only measure that was statistically significant across the cart capacities. And looking at the results, what we see is on the cart utilization, the highest we ever get to is 49%. At the 12 minutes, 12 cart capacity. And so what we're seeing is the carts are only ever about half full anyway, so there's no need to go to a 14 or an 18 cart capacity. So
sorry, just going back to our poll real quick, what you just said is that the cart capacity was not the constraint, right? And that
correct.
was actually the timing that made the biggest difference. So apologies to those of you who selected the cart capacity as the constraint. Turns out that it was the other one.
Yes, and that's it. The dispatch timer really had the greatest impact on our system performance overall. So looking a little deeper into the results for the 12 tray carts, the graph in the bottom right there really shows it that the maximum number of carts needed, which correlates to the number of staff, because we need people to push these carts, there's an obvious trade-off there versus the percent delivered after 30 minutes. All right, so if we wait 12 minutes, we need fewer carts, but we're much more likely to be late versus if we only wait 8 minutes. We're requiring more carts, more staff is really the costly part of that, right? Not necessarily the carts, but we're only at a 2% late in that case. So this is where we're providing the information to management. We're not making the decisions for them, but we want to provide them all the information so they can decide, is it worth hiring maybe 3 more staff members to be able to run an 8-minute dispatch timer. And so they're able to think through that, the cost versus the improvement in patient satisfaction. And then when we really dive into the use of the 12 tray cart, we need to consider a little bit more than just the maximum number. And so what this is showing, if you look, for example, in the front, the blue bars, the 8-minute dispatch timer, we see that 17 carts were in use for a very small percent. That's actually 0.01% of a day. So that might have been for a minute. We had 17 carts in use. Right? So do we really need to have 17 carts purchased? Or would 16 be sufficient, or 15, or 14? Basically, what happens when we actually constrain it and don't allow these resources to be unlimited? And so that's what we did in phase 2. As far as recommendations from phase 1, we again went with the 12 tray cart. We did not give a recommendation on dispatch timer. We gave that back to management and just told them what we found. And this is where they said, okay, let's put real staff schedules in there, add a little more of the realistic constraints, and provide better recommendations. They were sold after we showed them what we could do in phase 1. And so now in phase 2, we started actually looking at staff schedules, different serving hours, constrained resources.
So Seth, do you find that often in your projects that you do a phase one and then once you have buy-in and you've shown the impacts and people ask for a phase two, or was that unique to this situation?
No, that's actually how we do most every one of our projects. We start out with a simplistic model, something that is not as time intensive to put together, but that we can build on for a more in-depth. And we get management understanding how simulation works and the kind of data we'll need from them, because sometimes that's really hard to get in the first phases. They don't understand, why do you need all these details? What are you doing with it? And I don't really believe you can actually model what I do anyways. So almost always we do a initial phase to prove out the concept and get some feedback, and then we go in at a much detailed level. Fortunately, we've never had anybody still not believe us after phase one, but if they did, we would probably really think hard about continuing that project if we're not having the stakeholder support to go forward. Because one of the important things about modeling is implementing the results. And so if they're not on board for the model, they're probably not going to be on board to have us help implement the results. And that's really not a project we want to be involved with, so we'll spend some more time building out that relationship with them before continuing.
Sure. I think that's a really important point. Often I think, I'm looking at all of your results here and thinking, wow, he did a really deep analysis. And honestly, it can be a little intimidating for folks who are just getting started with simulation. But I think if you use that kind of approach of, let's start with something simple and then grow it over time, that can be much more successful in getting the buy-in and building skills at the same time. So thanks for sharing.
Yeah, and it's the best way, in my opinion, to build models. Start simple and then go in depth. It's many times too complex to try to jump in to everything right away. So just from building the model perspective, that's how we should be operating regardless. So it's good to keep the stakeholders in that loop as you do that.
Definitely.
So phase two here, again, what we're looking at, the operational staff schedule provided while we did this project was what they currently staff. And we put that into the original model, and we realized quickly there's no way that they're going to be able to handle this new system with their current staffing. I think the utilization was up around 140, 150% of staff. So we knew that wasn't feasible. So we needed to create some new schedules and provide recommendations of getting new staff, new FTEs on board. The other thing we wanted to do is look at the efficiency and effectiveness, right? So the first model only looked at the delivery of meals, but there's also the return process. And we knew from past experiences that by trying to combine trips, we could get the most out of it. So what we looked at here is combining the delivery and the pickup processes. So we'll take out the fresh meals, and then on the way back we'll bring the dirty trays for cleaning. And that's the return process here that we included. A few additional assumptions. We decided to, again, in the effort to be as detailed as possible in this phase, now we're including the food preparation time. So that's included from when the patient calls till actually getting the meal plated on the tray and put in the cart. And the cart cleaning time, right? So if we're picking up dirty trays, every time it comes back, we'll need to spend time washing that cart to get it ready to put fresh meals back in. We're, again, using the zone routing for pickup and delivery. The carts are modeled as an unlimited resource still, but they're limited by the number of staff available. And so modeling them both as limits, if we wanted to put limits on the carts, really was no benefit. It just added extra complexity to the model. Because what we were most concerned about is having to hire new staff, not purchase extra carts. So we let the staff really be the limitation on the number of carts in use at any given time. We did not include break times in the resource schedule, and that was management's request. And then we also adjusted the order distribution that would go from 7 a.m. to 7 p.m. We were originally 5:30 a.m. to 9:30 p.m., And management said, that's going to be too big given what you're saying about extra staff. Let's go down to 7 a.m. to 7 p.m. And after we go live, we can reevaluate from a patient side if we need to expand those hours. Performance measures here, we were able to really whittle it down from our initial set. What they were curious about here is service level. It defined as the percent of carts delivered in 45 minutes or less. And so that's from the time the patient calls till it's in the patient's room. We got rid of the 30, 40, 45, 50. We settled on 45 minutes as our time. And now that it includes all the food prep time and everything else, management thought this is the promise they want to make the patients, and how do we need to figure out how to meet that. Resource utilization, time resources are in use, resources being staff, and the total number of scheduled work hours in a day. So our objective here, determine the optimal staffing schedule, or best. I'll say optimal loosely. We didn't test every single option, but we did go through a strategic way of modifying the schedules. So we were trying to figure out which one allows for the highest service level as well as the highest worker utilization. Also looking at the most efficient delivery and pickup routing methods, and I'll show you those on the next slide. And again, here on the right, we show an example schedule. So management asked that we do a schedule by hour, not necessarily by shift. And so we were able to modify for each hour how many staff were on. And then at the bottom there, you see 8 p.m. to 7 a.m. We're not using any staff in this system. And I should note there, the 7 p.m. to 8 p.m., we operate 7 to 7, but 7 p.m. is the last time a patient can call. We'll still need to be able to deliver and pick up dirty trays up until 8 p.m.
So, Seth, I'm a little bit confused. If you can just help clarify for me. You know, I have yet to find a hospital who will let me bring staff in for just an hour of work. So, how do you balance the staffing schedules, given that it's fluctuating so much throughout the day?
Yeah, it'd probably be tough to find staff who would be willing to come in for an hour at a time too, right? So the nice part here is what management said is we realized that our staff can be flexible. And for this project, the meal delivery system was the most important and time sensitive. There's a lot of tasks that they have in the department that can be done at any time, things like food preparation for later in the day or maybe even for the next day, cleaning activities, stocking, a lot of things that can be just kind of fit in to help load balance. So say at 7 a.m. we might have 12 staff come in, and 9 of them are working in the meal delivery system and 3 are doing food prep for breakfast. And at 8 p.m. they would flux them over to the new system. So we were just specifically looking at the delivery aspect of this.
Great, thanks.
So I also said we were looking at a few different options for the delivery and pickup routing scenarios. We have 3. We have our original from phase 1, 3 zones, fixed routes. B is a little bit modified, and this is to help on the pickup of dirty trays. It rotates, so each time that they would go out in that route, they would start at a different nursing unit, so when they go through their lap, they would end at a different nursing unit so they can pick up all of the dirty meal trays and kind of rotate as they make deliveries. They're ending somewhere different each time. And then option C here is a 6-zone layout with fixed routes. And so what we're looking at here is there were some thoughts that a rotational route might be too complex operationally to manage. And we said, well, okay, what would happen if we get more granular and really break out our nursing units into 3 or 4 unit zones rather than 6 unit zones?
Makes a lot of sense. So this is exactly the same kind of scenario where you might get a team together and sit around a table and debate the right answer. So what we'd love to have is everybody vote again and pick which of these 3 scenarios you think will be most effective at meeting those goals that Seth has laid out for us. Is it to do the standard 3-zone route? Is it to do that rotated schedule? Or is it to do the 6-zone layout with the original operating, no rotation or anything? It'd be interesting, Seth, to hear a little bit about how you came up with these different options.
So the first one was actually based on how we deliver our linen. We do it in a zone base, and they visit each of the units based on a fixed route. The difference is when they pick up the dirty linen, they have to go down to the basement where the dirty linen chutes go. So it's not a worry about picking up the dirty meals on the unit. And that's what got us thinking about this modified schedule, so that each time they would end somewhere different because they're actually picking up the dirty trays on the nursing unit. And what we didn't want is for them to always end at the same unit and then have to backtrack to the other units to pick up on some schedule. And to clarify, we always deliver all of the meals first before picking up any dirty trays. So we have an empty cart for that split second there while the last meal is delivered before we pick up the dirty. The 6-zone was actually just a thought we wanted to explore, to think, should we be more granular with our zoning? And geographically, it worked out very well to do this type in our hospital based, again, on how the elevators are structured and how our towers are structured. It was intuitive to break them in half.
Great. Well, Stephen, if we can see the results, let's see what people were thinking. Excellent. Yeah, interesting. So, so nobody thinks that the original model was a good idea. So the rotational delivery schedule clearly is the winner here, followed by the 6-zone layout. It'd be interesting to hear the results, Seth. I think, my intuition would be that probably aligned with that the modified pickup schedule as well. So can you tell us what the answer was?
Yeah. So to get our results here, we went through a little bit of a scenario testing. We tested all the different scenarios, so each of these schedules for each of the 3 different types of delivery and routing methods across 24 hours. And so there were many employee schedules we looked at, and we looked at the 1-day first because of the computational time it takes. Again, we're running this. It's not the food services model so much as all of the network we had built to get the accuracy we wanted in our internal logistics model. The model took an hour or 2 to run each scenario, so we did it just in a 24-hour period. And then we took out of that the 7 highest performing and tested them in a 30-day period. And that's because we wanted to look at the variability and make sure the day that performed well wasn't an extreme outlier. And so we took the 7 best, looked across 30 days, and really, again, testing to maximize that service level and utilization, but also keeping the total employee hours and understanding. So comparing the 4 of the 7 best, right? So these are just the 4 best out of those 7 we took across 30 days. Looking at the service level and resource utilization. So service level is the squares up here at the top, and the triangles represent utilization. Option A is in green, B in red, and C is in blue. And so what we see here is that the 6th zone dominates in every one of the options, right? In service level, it's always higher using the resource utilization. So what this is showing is, if we look at, on the left, say, schedule number 3, we had 120 hours. Well, we're paying for those 120 hours whether we're efficient with our resources or not. And so just by changing the delivery method, we might be asking the staff to do more work, travel more frequently, because we're now going to 6 zones instead of 3, but we're able to achieve a higher service level. So if we're already paying for that resource, let's use them wisely. And so that's what we're looking at here, is now the trade-off between utilization, service level, but also looking at the number of hours involved. All right, so Schedule 7 is 129 hours, 2% bump in service level, which is nice, from 120. To get to 99% required 142 hours. So now management can decide, is it worth 13 extra hours of FTEs to get a 1% bump in service levels, right? And that's because we're getting into that tail of the distribution, the outliers.
So Seth, I think what you're telling me is that our intuition was wrong in this last survey.
I am.
That actually the 6 zone was the best?
And I would agree with everybody there that voted for the rotational. When we were doing this, my thoughts really were that rotational was the way to go. Again, we looked at the 6 zone, just kind of an out-of-the-blue thought, what if? Just to add another comparison, but the model allowed us to see that actually getting more granular in doing more work is going to be more effective for patient service levels, given our capacity.
Sure. It's almost, you know, if we stop and think about it, maybe it does make sense. When we think about lean, what it tells us is that smaller batch sizes are better, right? And so if we can break things down into smaller components, maybe it is easier to be efficient.
Absolutely.
That's really interesting. Thanks.
Yep. So our recommendations here on the 6-zone delivery layout, we recommended Schedule 7, which provided the 98% service level, 88.4% utilization. Again, we didn't think going up to that 99th percentile was worth the extra hours. Schedule 7 on the right there, you can see the staffing that we, the staff per hour that we provided to them. So they were pleased with the results. They were pleased that they had a starting point. Again, our conclusion, 6-zone facility layout was the best, 3 or 4 nursing units per zone, and it would require 129 hours with combined delivery and pickup services per day. Again, break times weren't included in that schedule, and that's going back to where management said that they can flex time, they can work because we're staffing by the hour. They can figure out where those break times should be included. So I want to thank you for attending. And Brittany, have there been questions submitted that I could answer?
Yeah, well, thank you for that, Seth. That was very, very interesting, and there are a few questions here. If you're open to them, we have a few minutes now. So, question from Tushar, which is there a possibility that when you have a very high utilization of a resource, say 96 to 99%, a minor variation in the resource schedule can have a cascading effect in throwing both utilization and service level off?
Yeah, I think so, and that's what we wanted to shy away from, is not necessarily having any resources that were utilized close to that 99%. And I think that's good practice, regardless of whether it's this system or any system, that you really want to target 85 to 90% utilization from your staff. None of us work at 100%. We might think we do, but there's fatigue, there's restroom breaks, there's all sorts of things that fit in there. And so that's what we were really not looking to go much over 90% utilization in anything we would recommend. So I would agree that if you get up to 99%, that's too high.
Seth, did you actually implement this, or what were the kind of the operational implications once you went live?
That's a really good question. As I said, it's not good to do a model if you're not going to implement it. So we did implement this here at GMC. Unfortunately, all of our recommendations, well, I don't want to say all of them, not everything was taken into account by leadership. So we tried to go into this, even after we went through and showed we would need more staff, leadership said, let's try to do this budget neutral. So do what you can with what you have. Unfortunately, we were seeing some of our patient meal times when we initially went live actually approaching 90 minutes, which is well outside of what we wanted. And so leadership saw this. It wasn't necessarily the food services management, but some of the others who had said keep it budget neutral. And finally they told management and food services, okay, we believe you now. Let's go ahead and get those extra staff in. So we did get the extra staff. They are running a zone delivery method using the dispatch timers and the cart sizes we recommended. One thing that they're still not doing is the combined pickup and delivery, but we are currently still working with them to figure out how to operationally implement that type of system.
So ultimately it ended well, even if there was a little bit of a rough start?
Yeah, and that's not unexpected, right? Because we might provide the recommendations and that department might be on board, but in any organization it takes certain approval from administration and finance to actually agree to expand budgets, especially when we're expanding the budget not necessarily for a revenue increase, but increased patient satisfaction. And so showing that the finance can sometimes be a struggle, but it's a battle worth fighting.
Okay. Well, thank you for that, Seth, and thanks, Brittany. I think we'll just finish up just now. And if there's some other questions, we'll get back to those after the presentation and back to everyone individually. And Seth, if you just want to click on to the last slide, just a few insights into what's coming up. First off, obviously, thank you to Seth. Great piece of work that you've done there. And we will, as I say, get the slides and the recording, which will be emailed out to everyone that has attended. And they'll also be available on simulatehealthcare.com, so everyone can get a good look at the info Seth provided there. So thank you again for that. Thanks to Brittany for also being involved in the discussion. And just a few things coming up for Simulate just now. Well, just on this previous slide, the next up is the workshop. Next workshop is going to be from IHI. We'll be taking a delegation over there. Brittany will be joining the folks there, and we'll be doing a live update from IHI. So join us there, or if you are attending IHI in Florida, December 8th to 11th, then please do say hello. We'll also November, we're also attending the Healthcare Design Conference, and that's on from the November 16th and 19th, and that's in Orlando. Obviously, a lot of the workshops and the work we see being done is quite design focused now. So we're looking forward to that, and Brittany will be attending there. And as always, we'd like to continue the discussion on Simulate in Health LinkedIn group. I'm pretty sure most of you are members of LinkedIn, so please do go over there and join the group, because we're always great to hear from people and share their stories, successes, and to get support as well from people, not just Simulate users, but people using simulation in healthcare in general. And well, I guess that's all from me, and thank you again to Seth, and thank you again to Brittany, and thank you most of all to everyone for attending today. So have a good day, and thank you. Bye-bye.